for metastatic colorectal cancer, we now have several late-line options. We have trifluorine tipiracil, we have trifluorine tipiracil with bevacizumab, we have regorafenib, and we have fruquintinib. So we almost have a relative embarrassment of riches in terms of new drugs. However, none of them work particularly well. I would say they're singles, they're not home runs. So anything we can do to try to steer patients who might benefit more exquisitely from one drug over another is really paramount, because historically we really don't have good biomarkers to select who should get what treatment. And we do know that with regorafenib, it's a single, but there's about 20% of patients who derive kind of long-term stable disease from it. So if we could better stratify who those patients are, it would be quite beneficial. I'd say it's a mix of both. So what they did was they took over 40 cell lines, and they knew that some of these cell lines were more sensitive to regorafenib versus others. And then they did broad whole exome, whole transcriptome type sequencing on them, and then used AI, basically machine learning algorithms, to figure out what is driving the predictability of who's going to respond and who isn't. And then they used the Caris Life Science database that has whole exome, whole transcriptome on many thousands of patients to verify that this was true. And what they saw is that for the responders to regorafenib, there were enrichment in certain pathways. So those are things like DNA repair and cell cycle type pathways. For those who were resistant, they saw other upregulation of various components within the tumor immune microenvironment, specifically increase in endothelial and vascular things, which is kind of how regorafenib works, but maybe those are in some ways resistance mechanisms to the drug. So it's a bit of a mix of both, but we now have an idea of maybe what's driving these resistance mechanisms. So if we can really use this assay in the clinic, then we can maybe see, who might benefit from regorafenib versus fruquintinib or trifluorine tipiracil plus minus bevacizumab, because we also showed that this predictive assay only works for regorafenib. It doesn't work for the other drugs. So it makes sense that this is an assay that seems to really predict for benefit from regorafenib specifically. And it's a drug that I think largely has been a little bit left behind now that we have trifluorine tipiracil bev, we have fruquintinib. It's still now the control arm in way too many studies, I would argue. But again, there is a subset of folks who do seem to benefit from regorafenib more than most. Maybe this assay will help guide us to selecting those patients. It's a great question. We've tested a number of stromal modifying agents in other disease types, especially pancreatic cancer, and it's always a double-edged sword. We disrupt one part of the stroma, we think it's going to make the drug work better. It actually makes things worse in some instances. And I think in this instance, it's really a sign that those are pathways whereby regorafenib works, and if the upregulation of those pathways is predicting lack of benefit, it's probably best to use a different drug.